for RAMP this evening. I am excited to introduce our speaker for tonight, Dr. Lucy Hindle, who is a dual qualified emergency physician and intensivist with extensive training and certifications, where she earned her medical degree from the University of Cape Town. She also completed her internship and community service in Gauteng. She's also a specialist in emergency medicine and critical care at the University of Cape Town and the University of the Witwatersrand. She is also a certified clinician in critical care, in nephrology and mechanical ventilation, and is also an instructor for the basic assessment and support in intensive care and level 1 ultrasound courses. Dr. Hindle also has been working as an examiner for the Colleges of Medicine of South Africa, where she has been applying her knowledge and skills in terms of training other clinicians, and has also worked in the Department of Toxicology, where she obtained a Postgraduate Diploma in Toxicology from the University of Stellenbosch, with a background that includes 3 years working as a consultant in emergency medicine at Baragwanath Hospital. I'm sure that already tells us the extensive experience she has in the emergency department and in intensive care. And we are so privileged tonight to have her amongst us, sharing some of her knowledge and skills to capacitate us as clinicians in our daily practice. And then she also joined the Department of Critical Care for a fellowship and continues as a dedicated intensivist in her care. And Dr. Hindle is particularly interested in toxicology, palliative care, and family communication, bringing compassionate skills and a skilled approach to her work in critical care. This evening, once again, Rodasa is truly honored to have you, Dr. Lucy Hindle. I will hand over to you to give us your presentation, and please feel free to ask questions at the end of the session. You can put them in the chat and we'll see what we can do. And at the end, please remember to listen out or look out for the next session that we're going to have and what topic we're going to be covering. Thank you.
Thank you so much for that really lovely introduction. Can you guys hear me and see slides? All okay? Great. All right. So welcome. Thank you so much for being here. Let me just see if I can get this to you. Yeah. Okay. So as the nice introduction said, my name is Lucy and I'm an emergency physician and intensivist. And I've got 3 big objectives for this presentation. Toxicology is huge, but hopefully by the end of this hour, we'll have an understanding on a clinical approach to overdoses, a simple framework that you can apply every time to every patient, and then just a thought about the challenges of rural settings when we're managing patients after overdoses or suicide attempts. So this is me. And I have a confession because I don't work anywhere rural. This is where I work. So this is Johannesburg, and it is very different. The setting is different, but it has real challenges. And I work at Barra, that's a goat. So that's probably about as rural as I get. And I've been there for 10 years. And I also work in private. So I work in Kempton Park in private. I did emergency medicine, I did critical care, and I love toxicology. So that's an introduction to me. But I know that South Africa is a vast place. So South Africa has different challenges depending on where you are and what you see. And the things are just going to be different. So we need one way to manage these patients that's going to be something you can implement every single time. Why does this matter? Okay, so we all know that we see patients coming in after suicide attempts or parasuicides frequently. It's a big problem in our emergency departments and clinics. We've got this very high burden of mental illness and suicide in South Africa, and yet we have very limited access to psychiatric services, especially in the rural areas, but even in urban areas in our state sector, access to care is very limited, and it's a very underserviced area. And the ED or clinic is often the first and only point of contact between a patient with a mental health crisis, which is what this is, and the healthcare services. It's a real issue. So in South Africa, more than 13,000 suicides annually, and this is probably underreported when we think of how suicides are reported on. Overdose is a very common method, and we know that for every patient who actually commits suicide or goes through with it, multiple patients will come in with a parasuicide or a suicide attempt into the ED. Stigma and underreporting of mental health issues is a major barrier. And just remember that every patient you see after an attempt, that is a patient with a strong risk factor for suicide in the future. So we do need to take it quite seriously. What agents are we looking at? Now, this is going to vary depending on where you are. So where I am at Barra, organophosphates are an absolute, I could say an epidemic, but where you are might be different. So you need to think about what you commonly see. In general, worldwide, paracetamol is the biggest. Tricyclic antidepressants are still very commonly prescribed for things like sleep and depression. So there's lots of them out there. Organophosphates, calcium channel blockers, antiepileptics, ARVs, other sedatives, you name it, it'll come in. So I wanted to give this idea that we don't have to learn how to manage every single individual toxin. We can have a structure and we can apply that structure every time we see a patient. And this comes from an article from 2006, but it's very well described on a blog called Life in the Fast Lane, which some of you might be aware of. It's an emergency medicine blog, Australian, but very useful. And it gives us this framework for managing patients who come in with any acute toxicology, including after a suicide attempt. And this is what we're going to look at. So every single time you have a patient that comes in, I want you to think of this framework and to actually go through it in a systematic way. And I can tell you that if you do that, you will not forget the important steps. So we'll go through each of these in more detail, but the mnemonic is resus, RSI, dead, okay? And at the end of it, hopefully your patient is not dead, hopefully your patient is doing well. So resuscitation, I think we're all pretty comfortable with. And this is medical stabilization. So when your patient comes in, a tox patient is just like any other critically ill patient, okay? And we all know that we manage critically ill patients with an ABC approach, all right? And that, I think, is pretty simple. And we're going to go through that in a little bit more detail now. All right. So the first thing is the airway. And we need to do this quite quickly, okay? And ideally, resource dependent, the resuscitation of this patient should be a team approach. Now, do you have a team available? I don't know. But you, the nurse, any other doctor that's available, if someone is really sick, try and get everyone there to at least get the patient stable, and then people can leave to go and continue with the rest of the work, which is always piling up in the background. So airway first, we need to assess this quickly. And what do we think of in terms of a patient that might be at risk? So here, I think patients that are snoring, have a depressed level of consciousness, that are vomiting or have vomit in their mouth, or you can see a lot of secretions in their mouth. Because those patients are at risk of either obstructing their airway, so you'll hear when they're snoring, or of vomiting and aspirating. So here, things like suctioning, jaw thrusts, use of something like an airway can be useful. And then don't ever forget that positioning patients can be very useful. So just turning a patient who's snoring, for example, onto the side allows the airway to naturally open. And it's a very low cost, low effort intervention that can stop an airway from obstructing. Some of these patients need intubation, and that's just the reality. So if they have a low GCS or seizures or some other reason why you need to intubate, you will need to go ahead and do that. But also just use your common sense. So if I have a patient that's come in and taken a lot of sedatives, for example, they will improve their GCS over time. So if you see that the GCS from when they came into now is gradually improving, maybe don't rush for intubation. Maybe do your simple maneuvers and see how it goes. Okay, so airway. Then breathing. All right, this is, we all know, respiratory rates, SATs we're going to get, but also look at the patient. How are they breathing? Are they someone breathing very deeply, taking very big breaths? And that might be a marker of metabolic acidosis that they're trying to compensate for. Or are they hyperventilating, very shallow breaths? And there we might think of something like opioids or benzos, where they are not breathing efficiently. We can provide oxygen here. So check a SAT, provide oxygen. And then I've just put this in because this really is a health crisis in Gauteng at the moment. But your organophosphates, the thing that kills them initially is this effect that it has on the pulmonary system, where the pulmonary system fills with secretions and they essentially drown. Along with all the resuscitation stuff, they need atropine up front, and they may need early intubation. So just bear in mind, our organophosphates are going to manifest with the breathing side of things. All right, circulation. Again, simple things. So what is the pulse? What is the perfusion like? Can I get a good cap refill? Is my patient hypertensive? And is it maybe because they were hypovolemic? So the drug has caused profuse vomiting or diarrhea? Or is it the effect of the drug? So things like an opioid are going to drop your blood pressure. Also consider things like arrhythmias causing hypertension. We're going to get early IV access. We know we need this. And in most patients with hypertension, we're going to start fluids early. And then early adrenaline, I've said, if the hypertension is persisting, there's often this reluctance to start adrenaline through a peripheral line. But if a patient has a low blood pressure and all you have is a peripheral line, please start adrenaline. It is better for the patient to have a slightly less concentrated adrenaline running via peripheral line than for them to be hypertensive for a prolonged time while someone maybe puts in a central line. Putting in central lines is not a fast thing, and it's often not part of that initial resuscitation. So don't worry if that's not in, rather start the adrenaline. Okay, then the next step is normally D, but D we've split here into 3 different things. So the first is seizures, and toxins commonly present with seizures, and it gives us a clue as to what it might be. So tricyclics, isoniazid, very, very common. And then all of our stimulant drugs, so things like ecstasy, cocaine, they can all come in with seizures. And the first line here, just if you remember, toxicology seizures, we treat with benzos. So not our normal anti-epileptics, we use benzos. So lorazepam or diazepam. And if they are still fitting, the next step would be propofol. Okay. Always think in South Africa, INH. We see it often because it's so commonly prescribed and people have access to it. So if you see someone come in with refractory seizures and they're not responding to your benzos, get that history. And if needed, give pyridoxine early. All right, hypoglycemia is our next step that falls under D. And we're going to check a blood glucose in all overdose patients. Everyone has been fooled by a hypoglycemic patient that comes in with a low GCS. And the minute you fix that low glucose level, the GCS improves. So check it and treat it if it's there, and reassess frequently. So we know a lot of our drugs in overdose can cause a hypoglycemia. And then the last thing under this D area is hypothermia. So patients who are fitting or very agitated. So think of our patients like our anticholinergic patients. They're very, very agitated and they use a lot of muscle strength, okay? That generates a high temperature. So stimulants, serotonin as well can do it. We need to check and cool those patients very quickly because this can kill patients rapidly. And then antipyretics are not effective here. So don't add something like paracetamol. We need active cooling. And if the patient's agitated or fitting, then we need to go back and give benzos because that was our first line for seizures and it's going to be our first line for agitation. So always remember that benzos are not a bad thing in tox patients who are hot, fitting, and agitated. All right, people love antidotes. People love learning antidotes. People love asking them in exams. But there's actually very few that you need to know off by heart to me, and very few that are useful in this resuscitation phase. And for me, this is kind of atropine for cholinergic toxidromes, because we know those patients will drown to death until you get atropine in. Pyridoxine for INH is, to me, essential. Your patient doesn't stop fitting till that starts going in. And then maybe Narcan for opioids. But remember, you can always assist the patient with ventilation, because that's the key thing. So even if we can't get Narcan, we could breathe for that patient in the interim. I would suggest avoiding flumazenol. It is in our resus trolleys and things, but often there's co-ingestions. And if I give flumazenol in someone who's on a benzo chronically or has taken something like a tricyclic, it can precipitate seizures. So you took a patient who was relatively stable but asleep, and you've now turned them into someone with refractory seizures. So I don't think that's helpful. So just be cautious on that. Only use these when the diagnosis supports the use, because giving things unnecessarily, example, flumazenol, might cause more harm than it's worth. Oh, sorry. All right, so we've gotten the patient to a relatively stable point. All right, the team came in, we did an ABCD approach, and the D included seizures, temperature, and hypoglycemia correction. And our patient now looks kind of okay, but we're wondering what to do, because what is actually going on with this person? So this is the next step. We need to do a proper risk assessment of this patient. And the risk assessment means that I need to work out, what did this patient take? When did they take it? What else did they take? And then what particularly about this patient makes them high risk to develop complications? So not necessarily a suicide, but for example, a 2-year-old who took 3 calcium channel blockers, that patient could die. But the same amount of drug in an adult is unlikely to cause harm. So I'm taking into account the patient factors, so comorbidities, the age of the patient and the size, and then all the drug factors. So what, how much, when, and what else, including non-prescription drugs. Remember, a lot of suicide attempts come in with things like alcohol, other things like bleach or a corrosive, or an illicit drug as well. So I need all of that information. And I need to gather information where I can. Sometimes people have this sort of negative feeling towards patients who have tried suicide, and they feel that they can't be believed. And while it is true that we shouldn't take what people say as gospel, the patient is still a very good source of information. So ask the patient, what did you take? When did you take it? Ask the family. Get information from who brought the patient in. What was on the scene? What did they find? Where were the packets? Okay, that I always want. And then go and ask the family, what's in the house? Okay, who's on what? Is Gogo on something? Is there someone on ARVs? Not this patient, someone else, and maybe there's INH. Get all that information and put it all together. And then if you need information, so you need information on what the drugs are and what they might do. I have done extensive work on toxicology, and I do not know all the drugs. It's impossible for anyone to know. So use the resources that you have. EM Guidance is a great online app. AfriTox, I'm going to go through later in the talk because it's just an amazing resource. And then your online things, Life in the Fast Lane has a huge toxicology compendium, and you can basically put in any drug and it will give you the toxic doses, how to manage, etc. So you don't need to learn this stuff, but if I didn't know that there was INH in the house, I cannot ever treat it properly. So information gathering is really key, and then use your resources to find out more about the drug. All right, just an aside, I don't know who is using these, but they do come up sometimes more in private. I do not find urine drug screens useful, and sending off a random array of screening bloods, so blood tests for different drugs, I also don't find useful, and I'll tell you why. So urine drug screens, you can see that if I test your urine and I come back with a positive result, it does not mean that you have that drug in your system, okay? And often what we see happening is that someone tests positive for something and the risk assessment stops there. But the risk assessment Cannot stop there, because what else did the person take? And did they even take that drug? It doesn't actually help me in my clinical management. So I would suggest not doing these, and I don't think they're done widely in state, but just a thing. All right, so the next step, once we've gathered all this information and we've resuscitated the patient, is the supportive care. And this is universal. This we should be doing in every single critically ill patient that we have in our ED or clinic. And just have some common sense here, okay? If my patient took a warfarin overdose and they have an INR of 10, they do not need thromboprophylaxis, okay? So I am not saying that every patient must get everything in this list. And this is fast hugs, okay? So it's just a mnemonic that you can tick off. But think about each of these things in every critically ill patient, and always put in a urinary catheter for our patients that are in resus, intubated, unwell, okay? We need to monitor output, but also a full bladder will make patients extremely agitated, and a lot of drugs cause urinary retention. So fast hugs is a mnemonic from the critical care setting. I use this mnemonic every day, but just go through it and think, does this patient need fluids? Does this patient need analgesia? And tick off. And even if the answer is no to almost everything, okay, it's fine, because at least you've thought about it. Then the last of this little bit is investigations. So the investigations that I think are essential are a glucose, as we said. I do a pregnancy test on every possibly pregnant person, and I'll tell you why. Pregnancy is a very high risk time. In South Africa and worldwide, it's a high risk time for experiencing intimate partner violence. So, and that can often be a trigger for a suicide attempt, and it can be a trigger for mental health crises. So always do a pregnancy test. It shouldn't really affect how you manage the patient, but it is something you should identify. Always do an ECG. It gives us so much information for so little cost. It can give us information about what drug the patient may have taken, arrhythmias, etc. And then a paracetamol level, for me, should be an absolute standard on every single patient that comes in, having taken anything. A missed paracetamol overdose is devastating, because that patient will go into liver failure. And we know that in our setting, access to something like a liver transplant is almost impossible. Paracetamol ODs can come in completely asymptomatic, so your patient looks completely fine. So before you send them home, check a paracetamol level just as a screening. Then everything else is only if indicated. So only if you really need that level or need that UNE or FBC or whatever. So think about, do I need it? And what am I going to do with the information before actually pulling that blood? All right, so then the DEAD part of it, so DEAD, the first is decontamination. So I've managed the patient, I've gotten a risk assessment. Now I need to know, is there anything I can do to basically stop the progression of this toxin and to kind of prevent further absorption of the toxin? So the first is skin cleaning. It's probably less relevant in patients with suicide attempts, but it is possible. So if there's, for example, a toxin on the skin, clean that off. And then I'm going to talk about activated charcoal and a little bit on gastric lavage. So activated charcoal is very useful. It works on many drugs, and how it works is that it has a very large surface area on this powder that you can see, and the drugs actually stick to it. They stick to it, and then they are passed without going into the stomach or the duodenum. The risk is that if this person aspirates it into their lungs, it can cause very severe damage. And we do sometimes see that it's given when patients are very drowsy, vomiting. That's probably not safe. So patient needs to either be fully awake or intubated. If they're intubated, we're giving it via an NG tube, and please make sure that NG tube is in the right place, because you don't want to give this and it's all gone into a lung that your NG tube is sitting into. So just caution there. It doesn't work for some drugs, so look this up before you give it, but just have in the back of your mind things like metals, and I always think it's because metal doesn't really like absorb to things, it can't stick to things. Paraffin, things like acids and corrosives. And that's also partly because if you've got a corrosive sitting in your throat, you don't now want to put another thing down that throat. And then organophosphates, also not helpful. So just think about it before you give it, and only for a protected or safe airway. And then gastric lavage used to be very common, and it's largely out of use. It can be risky. So the same thing, I put in an NG tube, I put in fluid, and I aspirate it. There's a risk for aspiration here. Having said that, over the last year, we've had some feedback from the pathologists who work on patients that come from Barra. What they've said to us is that they are seeing organophosphate granules in the stomachs of patients who have been in ICU for even a few days. So it's still sitting there in the stomach. So we've actually introduced it as a option in our patients who've taken organophosphates. These are intubated patients that we actually do gastric lavage, and we do see quite a lot of the organophosphate granules that come out. So I'm not necessarily suggesting this for widespread use, but I'm just sharing that we've changed our practice a bit based on that feedback from pathologists. We don't have evidence for it. And again, it can be risky only for patients with protected airways. All right, enhanced elimination is the final step here. So if I can't stop the drug from passing from the stomach or the duodenum into the body, can I get it out faster? So can I get it out without causing damage? And there's two things here. The first is, if I change the pH of the urine, sometimes what that does is a drug like a salicylate, so like aspirin, will pass into the urine. If the pH of the urine is different, it will become trapped in the urine and it will pass out. And I could change that pH by giving something like Sodabik. So that's an option, not for many drugs, but it can be useful for things like aspirin. And then the other way I could try and get drug out of the body is hemodialysis. So this is a dialysis machine here. It's one of the ones that we use at Barra. And you can dialyze certain drugs out of the body. There are lists of these. So if you have a patient with very severe poisoning, and it is a dialyzable drug, I know that access is difficult, but it may be worth chatting to someone who has the capacity to do dialysis and seeing whether or not it's an option. And here, think about your toxic alcohols like ethylene glycol, or things like valproate may be useful. All right, and then the final step here is your antidotes, or one of the final steps here is your antidotes. And these are not the resus antidotes. These are the antidotes that I need to start, not as an emergency, but I do need to give them because the potential is for ongoing further harm. Paracetamol, we have to give N-acetylcysteine. It works brilliantly, and it's going to stop that patient developing liver failure. Patients with iron need desferrioxamine, and that's going to allow the iron to pass. And then organophosphates will need it up front, but they need atropine. And then I've said ... at the bottom here. The list of antidotes goes on, and here you need to use a resource or something to help you with what to give, how to give it, how long. And ideally, you just look this up every time. And then the final thing is disposition. And this is much harder for you guys than it is for me. Okay, so where does your patient go? Do they need to be transferred out? How do I get them there? When? Why? Am I transferring them for dialysis or critical care? And I know that they're the challenges with rural hospitals. So access to ICU, dialysis, and mental health are very real issues. But obviously, we try. And then we've just got to have in the back of our mind that if I send this patient home, what will happen? So I need to try and do some sort of risk assessment to say, is this patient safe to go home? If they are safe from the medical side, I've assessed fully. Are they safe to go home from the mental health side? So think about, do they have prior attempts? Do they have mental illness? And that includes substance use, which is very widespread. Have they had a recent loss or trauma or chronic illness? And then internationally, male, gender, and older people are higher risk. In South Africa, however, we see that younger women are also very high risk. So think about that as well. When I chat to my patients and I take a history from them, are they currently still suicidal? Did they have a plan, and did they prepare for that plan? And did they think they were going to die? Or did they think that this was going to be, something that would get them the help that they need for a crisis rather than an actual attempt? How lethal was the method? So did they know that it was a lethal method? And did they seek help? Did they message someone? Did they ask for help? Or did someone else have to come and find them? And then before I send them home, I want them to be low risk. I want them to have a stable mental state and not be currently suicidal, and have some sort of reliable support system in place. Ideally, you also want them to come back at some point to a follow-up appointment. And I need to consider, what do I have in the local area? Is there a social worker? Is there any community psychology? Can I use the help of local family? And how do I get this person somewhere safe? If necessary, and I know it's difficult, but if necessary, patients need to be admitted, okay? These are high-risk patients, and we admit patients after every other or many other medical problems, and this is the same. So do they have any need for ongoing medical care? Obviously, then they would need to stay in. And here, we're going to think about our risk assessment that we did. Is this perhaps a medication that might still manifest problems later on? So is it a slow-release tablet? Is it something where they may need vitals and a check done in 12 or 24 hours? So always factor that in. Are they high risk, or do they have any ongoing ideation? And those patients, I'm not going to send home. Do they have active psychiatric symptoms? And then if I don't think they're safe to go home, based on my assessment of the patient, the family, the support, rather keep them in and try and get that plan in place. Document everything. So toxicology patients are complicated, and the decision to send people home is a difficult one. So document from the medical side and the mental health side, your history, your findings, and how you made decisions. Include patient quotes so that you've put in exactly what the patient said, and detail what your plan is. So if your plan is, I'm sending this person home with their family, they know to reach out if XYZ happen, they know to come back to the clinic for this follow-up. At least it's documented. And remember, medical legal things are real, and we should be documenting our decision-making as clearly as possible. All right, so I wanted to just go through a case study quickly. I actually am running, I think, ahead of time, but that's okay. So just a case study. So this is a photo from the Barra Trauma Unit. But I'm sure many EDs all over the country look like this on a Saturday night. And I know that we don't always have the time and space to manage our patients as we wish, but this is the reality. So you have a 28-year-old man, and he's brought in by family. He was found semi-conscious, and he took unknown tablets. There was no note, but there was empty paracetamol and amitriptyline packets nearby. And he's recently unemployed, and the family say that was the trigger. So remember that we're going to go through this each patient, each time. Okay, resuscitation, RSI, dead. So we'll do resuscitation first, we'll do a little risk assessment, and then we'll go through what the options are for decontamination, elimination, antidotes, and disposition. All right, so the first is an immediate resus plan. So this patient is semi-conscious. The airway is potentially threatened, okay? So we need to look and see, is this something that can be fixed with suctioning and positioning, or do I need to intubate this patient at some point? I'm going to give oxygen because I assessed and the SATs were low. When I look at the circulation, this patient is running a tachycardia, but the blood pressure is down. I'm going to start fluids immediately. We know that tricyclics are a risk for seizures. So this patient is high risk. I'm going to know I have benzos, and I'm going to know that if needed, I'm going to start propofol, okay? But I've got benzos ready if a seizure happens. I'm going to check for glucose issues. So checked was 5.3. I'm going to check the temperature, and that's 36. And this is something where a resus antidote might be useful. So you, in the back of your mind, remember that patients who've taken tricyclics might benefit from some Sodavec, and you're going to start that Sodavec. So get that going. I'm now going to do a risk assessment. So I'm going to do a very structured thing, and I'm going to sit and I'm going to work out what is the problem here and how do I manage. So how much paracetamol, okay? When was it taken? And is this a patient that I want to start on N-acetylcysteine, get a level? I'm always going to get a level. and then start depending on the nomogram. So how much paracetamol, how much tricyclics, when was this all taken? Were there any co-ingestion? So what else was there at home? Okay, I've heard about these two, but what else was there? Did the patient take alcohol? What other medication is he on? Does he have other illnesses that maybe make him vulnerable? So for example, someone who is a chronic alcoholic is much more at risk from liver disease from paracetamol. Then I'd want to do my supportive care and monitoring. So fast hugs. Okay, I've already said the patient needs fluids. I don't think they need analgesia or sedation. We know their GCS is already not fine. I'm not going to start thromboprophylaxis here. I want the head of the bed up. I'm not going to start ulcer prophylaxis. I'm going to check the glucose and manage it, and we'll see. Investigations, as we said, paracetamol level essential, okay, in every patient. And then an ECG. And if you look at the ECG that's on the screen, that is a classic ECG for a TCA overdose. We see a wide QRS, and we see this abnormal shape in AVF. So you can see this very abnormal QRS. That's going to be a sign to me that the tricyclics are important here. Okay, so that ECG, and the more you do, the more you learn these things. Okay, and then the final bit is the DEAD, dead. Can I decontaminate this patient? So yes, both paracetamol and tricyclics are absorbed by activated charcoal. So if I intubate this patient and put in an NG tube, confirm the NG tube is in, I could consider giving that activated charcoal. Can I enhance elimination here? Not really. Okay, so I don't really have an option for alkalinizing anything, and I don't really have a dialysis option here. But I do have an antidote. So Sodibic can be very helpful for the TCAs and N-acetylcysteine for the paracetamol. So I get that information on what they took, and I consider what antidotes might be useful. And then disposition. So I've already said that I landed up intubating this guy for low GCS. And now he's going to need admission to some sort of ICU or high care. Hopefully not for long, because his GCS will improve. And hopefully with the activated charcoal, all the medication I've given, this is going to be a reasonably quick critical care admission. And then he will need help with his mental health. I understand. Okay, the rural practice challenges are real. In fact, the challenges of healthcare in South Africa are real. Okay, Gauteng is not spared from the challenges. Staff shortages, equipment shortages, ICU bed shortages, big distances. If you've got problems at your referral hospitals with ICU bed access, that has a knock-on effect. And sometimes we have this feeling that we shouldn't intubate because where will the patient go? Okay, and that no one gets dialysis, so it's not even worth considering. But I just want you to think that this guy, he's a 28-year-old man. He's a member of society. He could recover very, very well, and he could go on to be an active member of our society. And I think we need to just really consider doing what we can, okay? And this is what you have to do in healthcare in South Africa. So do what you can with what you have where you are, okay? And I think if you're doing the best you can, if things are not available, you document. If you've tried to get someone somewhere and you can't do it, then that's okay, you tried. But we still need to be systematic and try as best as we can. All right, so just some key takeaways and resources. So luckily, even though we are a country with vast expanse and you might be sitting at a small hospital somewhere, we're currently sitting on a meeting with many people and you are part of a network. And that network is hopefully real. I use things like WhatsApp groups. I have trusted people that I call. And I still, even now, I have colleagues that I will call and chat things through with. So I say, please just help me. You know, let's talk this through. Is there something I've missed? Can you think why this patient is presenting like this? So who are those people in your network, and try and develop them. So if you have a relationship with maybe a consultant at a different hospital, they might be open to talking through cases, okay? I don't think anyone wants to really have chats at 2 a.m, but just for learning, you can always consider going through stuff later. Look at an ECG together, for example. And then I just want to quickly punt this, which is AfriTox and the Poisons Center. So the Poison Center is a 24-hour service. It's run by Stellenbosch. So it's between Stellenbosch and Red Cross. There is someone available 24/7 to answer the phone and talk you through any tox issue. It is a fantastic service. Okay, the people who are answering are doctors or pharmacists. They will sit with you and go through, help you with that risk assessment, help you with antidotes, help you think of things to decontaminate the patient. And they also help with gathering data. So you phoning them is a service for you, but they also get information from you. And toxicology and suicide in South Africa is so underreported. And we really need to use the service. It will help to gather information, and then hopefully there will be more resources put into this. And then AfriTox. So AfriTox is a online platform. You can have this for free if you're a government hospital. So please encourage your government hospital, your ED or your department to get an AfriTox subscription. You can put it onto any laptop or computer that you might have in the hospital. And this has every single medication, cleaning product, many herbal medications and other things on it. And it will give you details on what's in it, what's toxic, how to manage. So I think between AfriTox and the Poison Center, there's actually a lot of resource and help. And you are not sitting alone. You might be worried, you're sitting there somewhere, you don't have a lot of help. Use these, take the numbers and use them more. They are underused, I think, currently. And I'd just like to encourage it as a resource that all of us should use, even at academic hospitals, because it helps with that information gathering. So that's it. That's my talk for this evening. I hope it was helpful, and I hope that I've given you a systematic way to approach these cases for every patient, every time, and to just encourage you to use the resources that are available and reach out to people and develop your network, because I think it's so helpful for this lifelong learning in toxicology. Thanks so much.
Thank you so very much, Lucy. I think your talk was very brilliant in that it's quite practical for day-to-day application, especially in the rural settings. I think, the numbers that you've also given at the end really bring everything into a nice close. Thank you so much for that. I would like to open the platform now for any questions that you might have.
I see one in the chat from Melanie. So maybe I can just start with that one.
Yes.
So Melanie said, which regimen do you suggest for N-acetylcysteine, 2 or 3 bag regimen? Does it matter? So it does. The 2 bag regimen is as good as the 3 bag. N-acetylcysteine can cause side effects. So the 2 bag is probably better in terms of the side effects. So I think if you are comfortable with the 2 bag, I feel like it's fine. What I will say is that sometimes changing protocols can be confusing for people. So what I would suggest is don't change things unilaterally. So you as an individual, rather don't do it. Rather go to your department as a whole. So include, say, the medicine department and the ED, and say, can we look at moving to this? Because N-acetylcysteine can be difficult. We started in the ED, it goes to the medical department, and you don't want things to be confusing or missed or the doses seem unclear. Does that make sense? I don't know if Melanie is on. And then NG-Calc has an atropine calculator. Have you used it? Is it reliable? I haven't used it and I don't know much about it. Is this for calculating the dose of atropine for organophosphates? Hang on, I'm looking here. Melanie, are you here? Okay,
sorry,
so what I will...
I thought maybe I'd text in the case it was easier. But yes, so firstly, thank you for your response about the NAC. I appreciate that. The atropine is basically an atropine dosing. You can say whether your patient is an adult or a ped, and then you can say whether it's mild or severe, which is very unclear. And then from that, I think you plug in the weight and so on, and then it gives you, I just wanted to know if that reliable?
So I mean, this is a bit aside, but remember that in terms of organophosphates, South Africa and India are really the only places that see this in big amounts. So, and China a little bit. I think we use a 0.04 milligrams per kilogram as an initial dose. It normally works out in adults to about 2 to 3 milligrams, and then you double every 5 minutes. I don't think we see mild cases. I think we only really see severe. So I wouldn't use the MG calc. I would go straight to the 0.04 milligrams per kilogram as a dose, and that's adult or ped, and double that every 5 minutes. Okay.
Perfect. Thank you so much.
Cool. The next question is, does organophosphates typically present with seizures? Not typically. It can. So it can cross the blood-brain barrier, and it can give you seizures. What we often see is that the fasciculations in these patients are misdiagnosed as seizures. So patients, because they are fasciculating so vigorously, it looks like seizures. So it can be complicated. They can have a decreased level of consciousness. They can have seizures, but it's not commonly how they present. They normally come in with the secretions, the bronchorrhea, the sweating, and the fasciculations. And it can be confusing. So seizures and organophosphate poisoning can look the same, but it's not typically how they come in. Here, thank you. Okay, here's a comment. So do you think that contextual and individual management is equally as important as clinical management? Every patient should be admitted in the hospital and reviewed by the psychologist and not be discharged from the ED. So yes, ideally, okay, that would be what we did for everyone. It's not always realistic, and it depends on where you work, what's available, what's safe for your patient. If that's your hospital policy and that is what's feasible in your setting in terms of hospital beds, psychology access, then yes, that is ideal. If it is not feasible in your setting and it's not what you have available, then you must help exactly. So do all of the things you can to assess the risk, to develop that social support or have that social support for the patient. You have to find what you can offer in your setting. And if that is a psychologist, that's great. And if that is for the patient to come back to a social worker because that's what is available, then that is what we offer. Okay. Here, any updated advice on tank pull management? I'm not sure. I haven't seen one in a really long time. But here would be like the perfect place to phone the Poisons Control Center, because someone would talk you through the management. And that's what they're there for. So it is impossible to learn every bit of toxicology, and we don't do it. But for things like this that I don't see frequently, but maybe you do, definitely have a look on AfriTox. They've got the updated management on everything, or phone the Poisons Control Center when you have a patient. But maybe if you're interested, go and look on AfriTox and see. Another one. How much Sodexo do we give for TCAs, and whether the blood gas results matter? So for TCAs, we give Sodexo for seizures or for a widened QRS. So it doesn't matter if the patient is not acidotic. We still give Sodexo, and you can give 100 ml bolus, or like an amp is 50, but you give 50 to 100 until the pH is 7.55. So that's normally what we do. Okay. And what we want to see with that Sodexo is a narrowing of the QRS, and that maybe the seizures have stopped. So it's not really related to the patient being acidotic. We're giving it for the sodium channel effects, essentially, because the tricyclics act on your sodium channel, and we're giving the Sodexo to assist with those sodium channel effects in the heart and the brain. So that's what we want to see, is that those symptoms have abated and we don't go past a pH of 7.55. And I also want to just encourage, so the postgrad diploma through Stellenbosch, if you are interested in this, it is very useful. It's online, except for some contact time when you go to Cape Town. So if you are sitting somewhere and this is a passion of yours, you're really interested in tox, you can actually, you don't need a to be a specialist to do it, you can do it. And it's, I think, 1.5 years in total. Yeah.
How much is the contact time?
I think it's a week in the, I'm trying to think. It's a week in the maybe 2 weeks in the second year. So and it's very nice. You do like a snake handling course and you do various, fun stuff. But it's a very nice course to do. And it's with that poisons control center. That's the department essentially that runs it. Yeah. I don't know if there are any other questions. Okay. There we go. There's Mia. Thanks. So Mia did it with me. Okay, cool. So a week in the first and a week for lectures, yeah. This is my email address that I've just put on this last thing. If anyone has like a burning question or wants more information on anything, you're welcome to email me. Depending on how busy I am, my response time might vary, but you are welcome to send me an email. Yeah.
There was a request for your slides. I think the very first comment was
that's absolutely fine. I'm more than happy. I don't know if this was recorded, but
it is
recorded. Yeah, more than welcome. I'll email them through. Yeah.
Thank you for that. So I'm seeing people starting to jump off. I am assuming that there aren't any more questions.
I don't see any more questions. If anyone has any other questions, really, you are welcome to email me and have a look. Thank you so much for joining and giving up your time, precious time, midweek.
And well done, Lucy. That was a brilliant presentation, very practical.
Thank you so much. I really appreciate it.
Yes. So the next webinar will be on the 4th of June. That one will be on wound assessment and dressings. The presentation will be by a surgeon based in East London. So please look out for that one as well and do register and join us. From Rudasa, I am Dr. Mbangata, and I thank you so much for being with us this evening. Thank you once again, Lucy. I can't thank you enough.
It was an absolute pleasure. Thank you. I've just said to you, should we send you our email request? What I'll do is I'll send it through to you, I think, and then maybe you can forward it out to people who request. Yeah, sounds good.
Sure.
And then if you've got the recording, you can also send through. Perfect. Yeah. Thank you so much.
Thank you so much, everyone. Good night and God bless.
Good night. Go well.